Okay, so let's start. Thank you very much, everyone, for joining me today. I'm Dr. Mirmahin Ashraf, and today is the International Day of Radiology 2024. So we are trying to celebrate it with you. So today we will talk about some ultrasound cases that comes in our regular practice, and it will be a 2 hours long session, I hope. We'll try to share 25 ultrasound cases with you of different topics, different scenario will be given. I hope the next 2 hours will be enjoyable for you, but I'm not sure because some cases are a little bit confusing or boring maybe. So anyway, let's start. I hope everybody has joined me. I just let me check a little. Okay, yeah. If you are connected to our live program, make sure to comment on our Facebook page, Imaging Study, from where we are casting the video. So we have posted the same content to many of the groups. So please, if you want to ask any question, try to put it on our live video section so that we can solve your questions also. So after the session, we will try to solve your questions. So don't forget to put them and let's enjoy. So we have a YouTube channel. If you're new to our program, we have a YouTube channel named Imaging Study, which already has got, I think, 58 plus K subscribers. So thank you for being with us. And we also have some videos, and unfortunately, we are very irregular about that. Anyway, let's start with our first case because the time is short. So the first case is a 52-year-old male patient. He came with an upper abdominal pain, especially on the right side, and also some body itching history. Whenever patient comes to us with body itching and upper abdominal pain, our first priority goes for the pancreatic scan. So let's start with the liver as a protocol. So we started with the liver, and you can see many things here. Like you can see multiple tubular structures within the liver, including both lobes. So these are dilated bile ducts, obviously, and definitely we will search for the cause. It might be calculus, it might be malignant, anything can happen. We'll go further. So here we are trying to focus on the pancreas. It looks quite normal, but when we are looking at the CBD, something is moving here. So there is a hyperechoic structure, I think. So that might be a calculus. Yes, there is a calculus here. It's quite trying to move. So it's casting some shadow, but the bowel are making some disturbance. So we need to look it from different angle. So let's look from a different angle. I'm rotating the probe a little, and you can see this calculus right here. So it's at the distal CBD. So we need to adjust the probe. Let's look at this picture. So here's the CBD, and this is the duodenum, and posterior to it, you can see this common bile duct, and this is the calculus casting posterior acoustic shadow here. So it's located at the distal CBD, causing the obstruction over here. So the proximal part is dilated. We have changed the transducer. Now I'm using the 3-dimensional transducer. It sometimes gives a good resolution. So I have changed it, and you can see the calculus here at the distal CBD causing proximal dilatation. So it measures around 28 millimeter. So it's a big one and causing obstruction at this part. So we have looked at the gallbladder, and you can see the gallbladder wall is also thickened, but the gallbladder is not distended. And you can see some slurs over here. So these are the dilated biliary channels. Now, this is not the end of this case. We want to put some 3D over here. So you see, it's a luminal structure. The lumen is quite dilated. So you easily can use 3D to demonstrate this calculus within the common bile duct. So we have put the color 3D box like this, and we have put the green line just above the calculus and trying to make it quite parallel to the CBD to get a good view of the lumen. So this is the reconstructed 3D image. Now we want to edit it a little. So after some editing through the threshold, transparency adjustments, everything, some rotation, now you can see this is the CBD, common bile duct, and this is the calculus at the last part. So it looks like a gallbladder actually. So we use the OmniView option. I'm using the G machine. G is not sponsoring the video, very bad, but I'm using that machine. So it has got an OmniView option here, with which you can just choose a simple area and just move the cursor and see it in different sections. So here I have chosen this slices, and I put it here in the 3D image. So you can see this is the calculus and this is the proximal dilated lumen. So I've rotated a little, and you can see this is the stone causing obstruction over here. So let's magnify the 3D image, and you can see this is the calculus and this is the dilated CBD on a 3-dimensional image using the OmniView option of the machine. So here's the calculus and this is the CBD. So this is 2024. So our pictures should be quite modern, I think. So that's why we have tried to give this type of picture. So here's the tomographic ultrasound imaging mode, or TUI mode, where you can take some slices from the chosen part, and with which you can actually show some CT scan like slices or tomographic slices. So here I have chosen this part from this cross section of the dilated common bile duct, and you can see all the long section pictures of the common bile duct appeared here, and there is a stone over there. So let's magnify a little, change some contrast, and you can see this stone at the distal common bile duct. Why am I doing this type of boring works actually? I'm doing it because this is a common bile duct calculus, okay? But there are some cases where you can find common bile duct calculus causing obstruction, whatever, but distal to the calculus, there might be a macellation. So I'm just trying to exclude any possibility of macellation at the distal CBD. That's why I am doing a lot of exercise here. So here's the picture, and this is the distal CBD calculus or choledocholithiasis. So this was a case of choledocholithiasis with dilated biliary channels, and the gallbladder wall was thickened with luminal biliary slurs. Okay, let's jump into the second case. If you have any question, feel free to comment down on our live session, actually not in the group post or in my profile post, whatever. Try to post it in the live video part so that we can answer your questions after the session ends. So the next case is a 36-year-old female patient who complained about severe left lower abdominal pain with fever. So we thought about some inflammatory condition, hopefully. So she was admitted to hospital and was given injectable antibiotics. Now, there is a history. She had gone through a total abdominal hysterectomy 1.5 months back. Now she came with severe pain and fever. So fortunately, she had already gone through a pelvic MRI, so my diagnosis was quite easy. But let me show you what I have seen in this patient. So that was the urinary bladder, and lateral to it, there is a cystic lesion over here, but this is not quite a good cystic lesion. It looks like a hazy mixture. The patient had a hysterectomy. So if there was any cystic lesion over there, it should get removed during the surgical procedure. So I think it's a new lesion. So you can see it's quite hazy, not completely anechoic. So we need to evaluate it with different settings or options or different adjustments. So I have changed a little, and now you can see the lesion is quite hazy. It's a hypoechoic, and you can see luminal debris over here. And surrounding fats are thickened. These are thickened fat surrounding it. So this should be an inflammatory collection or abscess. We need to confirm it using the Doppler. So we have put color Doppler, and you can see some vascularity surrounding this lesion. Actually, this patient had gone through an pelvic MRI about 1 or 2 weeks prior to this scan. So at the time, the vascularity was quite high, and also the lesion was just double to this size. So this patient is improving, but when I was scanning this patient was having chills and rigor. So the condition was still very feverish. So anyway, the lesion was around 4.3 into 4.1 centimeter size. On the 2 week earlier, it was around 9 centimeter size. So the condition is progressing. And after 1 week, patient came again. So at this time, the pain actually reduced and there was no fever. So patient looks healthy actually at that time. So we scanned again and there was no pain at that side. And you can see the abscess got reduced in size. So, and the surrounding fat thickening is also got resolved. So the condition is quite improving, we can say. So it's quite a healed abscess right now. So we have put color Doppler, and now you can see there is no prominent vascularity surrounding it. So this is the condition of the abscess after 1 week, and it is now 2.5 centimeter long. So we can say it's in a good condition. So patient came again after 1 month, and now there is no pain, no fever. So she's now coming from home, already got discharged from the hospital. Now you can see this is the lesion right now. So it's very difficult to identify right now. And there is a tiny hypoechoic round cystic lesion there. So we have magnified the image, and you can see this cystic lesion, and there's a very tiny cystic lesion over here. So this is the condition. The color Doppler shows no prominent vascularity, obviously, because this is a healed abscess. So this was a case of pelvic abscess or left adnexal abscess. Let me just shake the live content a little so that I can see any abnormality going on there. Okay, sorry. Okay, so everything looks quite good. So now come to the case number 3. So it's a 7-month-old male baby. Okay, so he was sent by a dentist for evaluation of his lung lesion, his tongue lesion, sorry. So there was a big tongue lesion, and I was trying to take a picture, but couldn't get the consent from the patient's authority or patient's mother. So we couldn't proceed. Anyway, the baby had tongue swelling at the tip of part since birth, and it's just the tongue is coming out from the mouth. So it looks like a macroglossia picture. So they were suspecting about some hemangioma-like thing or vascular malformation. So it was sent to us for further evaluation with high-frequency ultrasound. So here's the picture. We have put ultrasound probe over the tongue, and you can see a cystic lesion here, but the internal content looks hazy. It's like an endometrioma-like picture, but don't say it's an endometrioma. It's a hazy content, and there is no pain. Baby was not crying. He was playful, actually. You can see the contents are moving, and it's very difficult to adjust because the baby was moving his tongue. So if I freeze the image, I can show you an important thing. If you freeze the image, you can see this cystic area has a wall. And if you check carefully, the wall has different layers. Not a single layer like a cyst or something. You can see some hyper layers. Whenever you see a cystic lesion with multiple layers like hyper, and the luminal content is a little bit hazy, it shouldn't be counted as a simple cystic lesion. It's something different. So let's look at another picture. Now the baby is a little bit stable. So you can see the hazy content inside and the wall is slightly thickened, but there is no inflammation. Okay, so surrounding area was normal. Obviously, we have to confirm it with color Doppler, but it was very difficult to use color Doppler because the baby was moving the tongue. So I was fortunate to take the picture of this part. You can see this cystic lesion has a multi-layered wall. And here you can see an incomplete septation. This incomplete septation is a little bit important to exclude the other differentials actually. So anyway, let's look at another one. So here's the color Doppler. This is the normal tongue vascularity, nothing else, but there is no apparent vascularity or abnormal vascularity inside or surrounding area. So there is no vascular communication and inside material is not the venous flow. So this is completely a cystic lesion with multi-layered wall, hyper. And whenever you get a cystic lesion with multi-layered wall with no prominent vascularity, and especially if it is located at the anterior part of the tongue, it should be counted as a Foregut duplication cyst of the tongue. So you may miss it as an hemangioma or vascular malformation, but this is a Foregut duplication cyst of the tongue. So make sure it should have multi-layered wall. Okay, so the baby was very cheerful. Now come to the case number 4. It's a 3-year-old male patient and came with a right upper abdominal pain. Okay, so we hope it will be not a very difficult case. So here's the intestinal view. So whenever I show you intestine, I love to show you something. So you can see some multiple lymph nodes over here, some tiny lymph nodes, but obviously I'm not focusing on the lymph node. You can see some tubular echogenic motile structures. They were moving actually. I'm just bracing over the intestine to make them move. And these tubular structures within the intestinal loops are the ascarias lumbicoides. So this is the ascarias. So these helminths were moving and the patient was crying or shouting. So fortunately, we could diagnose these helminths because these are not very common nowadays as the hygiene has got a very good level in our country, and especially where I'm working is a residential city area. So this type of helminthitis is very uncommon here. Okay, so here you can see the ball is moving. Here something else is also moving. So there were some, these are the, let me freeze it a little. And now let me show you. So these are the worms. So these are the worms moving within the small intestinal loops. Okay, so this is the worm. So let's jump here. So these are the worms within the intestinal loops. There are many hundreds of worms here. You don't need to count them. So I'm just allowing them to move a little so that we can see them quite well. So these are looking like French fries, I think, or noodles. So these are the worms within the small intestinal loops, and the patient was a case of intestinal ascariasis. So you can see many worms over here within the small intestinal lumen. So it's a case of intestinal ascariasis, quite easy case. So now come to the case number 5. So it's a 42-year-old female patient. So fortunately, we are getting a female right now with a low abdominal pain. So let's see what we can get on ultrasound. So here's the picture of the uterus. So it's a bulky uterus, I think, and you can see this is the endometrial lining. So this is the antiomyometrium and this is the posteromyometrium. The posteromyometrium looks quite thickened and heterogeneous. You can see some cystic spaces here. So this cystic spaces and heterogeneous appearance definitely indicates adenomyosis. I think I'm not showing you for the adenomyosis in this case. So let's go a little. So it was a little bulky uterus and the posteromyometrium is more hazy. Obviously, the antiomyometrium is also involved, but the posteromyometrium is thicker than the anterior one. And there was echogenic areas, focal areas at the posteromyometrium, making it a little bit heterogeneous. Anyway, so let's look at the transverse section. So still, this is the endometrium, this is the hazy posteromyometrium, nothing else, but you can see the adnexal doesn't look quite normal. So there might be something abnormality going on there. So let's jump into the right adnexa. On the right adnexa, you can see the tubular cystic area with some incomplete septations. So this tubular cystic area definitely indicates fallopian tube dilatation, which we call the hydrosalpinx. So this is a case of right-sided hydrosalpinx. Okay, we are not satisfied. We want to look a little more. So here's another view. So you can see this multiseptate cystic area, which is incomplete with incomplete septation. So these are nothing but the dilated right-sided fallopian tubes. So we call it the hydrosalpinx. Okay, now come to the left side. On the left side, you can see two different lesions. You can see these are the dilated tubes here also, but the dilatation is a little less than the right side. But you can see another lesion here. There is a round or oval hypoechoic cystic area. This is the endometrioma or chocolate cyst here. So we have got multiple abnormalities here. So this is the chocolate cyst. This is the hydrosalpinx on the left. We saw the right hydrosalpinx also, and obviously there was adenomyosis. So multiple abnormalities. Ignore this one. So this is the hydrosalpinx on the right. This is the endometrium on the left and hydrosalpinx on the left. So we have got adenomyosis, bilateral hydrosalpinx, and with left adnexal endometrioma. So the endometrioma with less than 10 centimeter size are counted as Urers ultrasound score of 2. And we don't have the color Doppler picture right now, but there was no, obviously there was no internal vascularity and the color score was 1. So now come to the case number 6. So it's a 7-year-old male patient had got the left posteromedial distal arm painful soiling. So this is not an abdominal case. This is the arm case, very commonly seen in our practice. So this is a picture of the left arm, distal arm. So you can see some hazy content here, some fat irregularity, and there is a kidney over here. Don't call it the ectopic kidney on the arm. So this is something else. Whenever you see a kidney over any other area like hand, like inguinal region or something like that, it should be counted as a lymph node. So this is a very common area. This is a very common area for the supratrochlear lymph node, and it can get inflamed. So lymphadenitis or abscess formation is very common at this part. Okay, so this is nothing but the lymph node. It is enlarged and surrounding abscess is seen here. So this is a hazy content with fat plane, irregularity and thickening. So let's put some color Doppler. On color Doppler, you can see the lymph node. This is the lymph node with a pseudo kidney appearance. It completely looks like a kidney. And you can see very high vascularity. So it's a case of lymphadenitis, and the surrounding abscess formation is seen here. So you can see the hazy content there. So we have measured the supratrochlear lymph node, and you can see the measurement here. And we have took sample from this area. You know, whenever you see the vascularity within the lymph node, you should check the resistive index of that part of the supplying artery. If it is less than 0.7, so you should count it as an inflammatory condition. Here you can see it's less than definitely 0.7, it's 0.56. So definitely it's an inflammatory condition. So this is the surrounding abscess, which is also common. Sometimes due to abscess, you even may not see the lymph node as it has already gone necrotic changes. So putting vascularity may guide you to find the lymph node. So this is a case of supratrochlear lymphadenitis with abscess formation. Now case number 7. So this is a 52-year-old male patient who came with painful penile erection for 3 months. I just was amazed to know that 3 months. So he said, yeah, 3 months. So painful erection for 3 months. Very grateful. Okay, so we did an ultrasound scan before and after oral drugs. So we have used the tadalafil. I think, I don't know about the trade name in your country, but we call it tadalafil. So before drug, we saw an erected penis. You can see all the sinusoids are filled with blood. It's interesting, but you can see these are the cavernosal arteries. These are the cavernosal arteries. You can't see the lumen. So the cavernosal arterial lumen is collapsed. So if they're collapsed, then how can you get the blood? So I think these are not the flowing blood within the sinusoid. So these might be the thrombosed areas. So we need to check it carefully. So this is the right corpus cavernosum, and this is the left corpus cavernosum. So all the sinusoids are dilated and filled. So here you can see the cavernosal artery, which are completely collapsed. So you can't see the lumen. And you can see all the venous sinusoids over here. So we have put color Doppler. You should see some vascularity. I'm compressing, but there is no vascularity, no flow within this corpora cavernosa. So definitely these are thrombosed sinusoids. So the venous sinusoids are thrombosed already. Let's look at the other parts. So here you can see the superficial penile vein at the dorsal part. So it's giving a good flow. Normally you can see this type of good flow. You have to press and see the flow within this vein. And you can also see some flow here, which are the dorsal penile arteries. So these vessels are working right now. So let's put some drug and check the patient. So after 60 minutes oral, our clinician suggested to give the oral drug. Definitely in this case, you won't try to push the injection. So we just use the oral drug as clinician required. So after 60 minutes, there was no flow within these vessels, obviously. So these are completely collapsed. So you can see the sinusoids. I'm using Doppler and putting pressure, but there is no vascularity, no flow within the cavernosal artery or within the sinusoid. So these are the thrombosed sinusoids now. So again, another part of the corpus cavernosa, and there is no flow within this area. So we can't see any flow within this cavernosal arteries actually. So we tried a lot to see the lumen, but these are completely collapsed, so you can't see them. So here's the color Doppler, and you can see after this 60 minutes, you can't see any flow within this cavernosal artery. So here's the dorsal aspect, and with color Doppler, you can see two arteries are pumping blood. So these are the dorsal penile arteries. So in case of thrombosis of the venous sinusoids, these arteries play a role to supply the skin and surrounding glands and surrounding areas as much as possible. And you can see at the central part, this is the superficial dorsal penile vein. These vessels usually supply the skin and the glands. but in critical situation, they are the main role-playing vessels. So this is a case of venous sinusoid thrombosis of the penis, which is known as ischemic or low flow priapism. So there is a high flow priapism, which is seen in the traumatic cases where arteriovenous fistula happens. So this is a case of ischemic or low flow priapism. Okay, let's join the case number 8. So this is a 3-year-old male patient who came with a lower abdominal pain. Okay, so let's look at the picture. So this is the picture of the around the para-aortic region on the left side, left lower abdomen, you can say. I can see multiple cystic areas over here. So there are multiple cysts. Now, this is a male patient. So if it was a female patient, I can think about a lot of different things, but this is a male patient. So let's look at another picture. You can see the urinary bladder, and lateral to it, there are multiple cystic areas over the around the mesenteric region. So these are oval cystic area, very much well defined, and you can see some calcifications, I think, also. So these are the cystic lesions, nothing else. This is the common site where we love to search for the enlarged mesenteric lymph nodes in the pediatric patients. But I can't see any enlarged lymph nodes. Rather, I can see multiple cystic areas at that location. So let's see another one. So here you can see a calcification also, which is interesting. So these are the multiple cystic areas within the mesentery around the para-aortic region or lateral to the urinary bladder. So at the lower part. So this is the common site for the mesenteric lymph nodes, and you can see only the cystic areas, not the lymph nodes. So definitely it should be called the mesenteric lymph node or malformation or mesenteric lymphatic malformation. So these are the lymphatic malformation actually. So whenever you see multiseptate cystic areas in the location of regular lymph node, you should think about the lymphatic malformation. So this patient is a case of lymphatic malformation. Okay, so they will come like this. Now the case number 9. This is a 45-year-old male patient with CKD, chronic kidney disease. So, okay, let's look at the, okay, so these are the kidneys. You can see these are echogenic kidneys, and the right one is relatively small in size. In my country, a more than 8 centimeter length of the kidney is counted as normal. It differs from country to country because the body status and height is not similar to other countries. So we follow usually 8 to 12 centimeter normal for our country, but it varies depending on the height of the patient. So anyway, the kidneys are echogenic, but this is not the focus of my this case. So I was just scanning the patient, and when I put color Doppler over the left kidney, that look, this is the important. Whenever you are using ultrasound, this is an echogenic kidney. You are expecting to get very less amount of flow in these kidneys. Okay, because these are already got fibrosis or something like that. But you obviously should use Doppler. So we put color Doppler, and on the left kidney, I was got amazed. Look at here. I can see artifacts from my machine. Like my machine is not a very bad machine, I think. Giving this type of artifact is very unusual for me. So I saw nothing on that kidney, but now I can see many artifacts and many aliasing over the left kidney. So let me make it a little clear. So I have used the linear transducer now. With linear transducer, you still can see this artifact over there, but there is no calculus. Trust me, there is no calculus at that part. So this is not the twinkling artifact. So we call it the confetti artifact. You know, the confetti, like on the birthday party, you just put like a gun. So this is the confetti artifact, which is commonly seen in the arteriovenous fistula formation. So let's look from the different angle. So there is a confetti appearance here. So the patient is quite middle-aged, so possibly the patient didn't give me any history, or he was a little bit confused. So there should be a history of biopsy from the left kidney. So a post-biopsy arteriovenous fistula formation is not very uncommon. So you need to carefully observe the patient. So this is the confetti appearance, and this is due to the arteriovenous fistula formation within the left kidney. Now, we need to confirm it a little. So we are using the pulse wave Doppler. So on a spectral Doppler, you can see a sharp peak and spectral broadening, and very unusual type of flow, very high velocity flow was also seen there. So the veins within this part show the arterialization. There is no venous flow. Okay, so these are all like an arterial flow. So that indicates there is a fistula formation over this area. So we also check the aorta of this patient. The patient had aortic calcification and atherosclerotic changes, which caused a moderate luminal narrowing or stenosis at this part. Okay, so this was a case of bilateral chronic nephropathy with a left renal arteriovenous fistula formation, possibly post-traumatic or post-iatrogenic maybe. Okay, so case number 10. So we are at the half of our session, I think. So this is an 8-year-old female patient came with the lower abdominal pain. There was urinary incontinence, history of urinary incontinence, and the urinary bladder extrophy was found at birth. So that's an interesting congenital anomaly. And it was fortunately repaired, I think, at the age of 4 or 6, I have forgotten. So the patient now came with a urinary incontinence with some retention. So the patient was referred to our center for further evaluation. So when we are just scanning the patient, you can see this is the urinary bladder. There are debris, but I have seen something else. So there was a calculus here, a large calculus, but you can see some tubular structures just having some peristaltic movement, and you can see internal flows. So these are the dilated ureters with debris inside. So on both sides, the ureters are dilated, and also the urinary bladder wall is thickened. So this is a case of chronic cystitis with bilateral hydroureter. I don't have any picture of the kidneys, but patient obviously had bilateral hydronephrosis. And you can see the thickening of the wall thickening here. And there is a big calculus within this urinary bladder. So patient was around 8-year-old. So I was a little bit confused that how this bladder can have this type of situation. So it's very unusual. Patient gave me the history that there was some surgery gone at the early age, but he can't give, patient's father can't give me any paper, couldn't show me. So I was a little bit confused. So I just wanted to check the patient as it was an interesting case with X-ray. So here you can see the urinary bladder wall is thickened. I have measured it from different angles, and the ureter was also dilated. Both ureters were dilated. And you can see there is a large calculus, very round shaped calculus within the urinary bladder lumen. So it should be interesting if you can see this stone on CT or X-ray. So we have done X-ray, and you can see an egg-like stone within the urinary bladder. So it's an interesting stone, but here are some extra findings. You can see these are the pubic bones separated from each other. So there is no fusion of the pubic symphysis out at the midline. So this is a case of bladder extrophy where you will see a wide separation at this part. Anyway, so this was a case of chronic cystitis with vesical calculus and bilateral hydroureteronephrosis. So case number 11. Now, this is an 28-year-old female patient with 8-month plus amenorrhea. So fortunately, we are getting a pregnant patient right now. And there was there was a history of cesarean section. Okay, so there might be something bad coming right now. So there is a history of PV bleeding also. So let's see what we have got on ultrasound. So this was a case of around 32 plus weeks of gestation. So everything looks quite normal here. And when we check the placenta, it completely covers the os. So this was a central or complete placenta previa. But we can see something abnormality going on here. You can see some venous channels, so you really have to be a little bit careful. So let's see on real time, you can see multiple large vascular areas within the placenta. These are called tornado vessels or lacunar vessels. So whenever you see the lacunar vessels or tornado vessels, you should put color Doppler to see the flow. If these are the venous legs, you won't see any flow within, but if these are the tornado vessels, like tornado, you will see inside flow. So if we can see the flow within these vessels, then we'll go for the placenta accreta spectrum or PAS. So let's see on Doppler. Here on Doppler, you can see aggressive vascular supply within the placenta, but we need a little more clear view. So let's change it from curvilinear to linear transducer. Here on linear transducer, you can see these large tornado vessels within the placenta. So let's see from a different angle. And you can see these are the large tornado vessels. So we need to also focus on this part because this is the area of cesarean section where the placenta would invade. So here is the color Doppler, and you can see very high flow within this venous channels, or these vascular channels. So this indicates that these are the tornado vessels or lacunar vessels. So this is the case of placenta accreta spectrum. So here you can see these tornado vessels completely filled with flow on Doppler. Now, if you look carefully at the CSS scar area, you can see this area quite irregular and some bridging vessels there also. Now, we call it the placenta accreta spectrum, and with MRI, we can further differentiate among the placenta increta, accreta, and percreta. It's not end with the ultrasound actually, so we can go for the MRI also. But with this image, can you tell me what should be the probable diagnosis? Is it placenta accreta or increta? Not the percreta. I can exclude that. Is it increta or accreta? Tell me in the comment below. So this is a case of placenta, central placenta previa with the placenta accreta spectrum. Nowadays, we call it placenta accreta spectrum. Okay, so case number 12, this is 33-year-old female patient, came with a chronic lower abdominal pain. So let's see what we can get on ultrasound. Here is a TVS image. You can see on TVS, just let me freeze the image. Like Nebulian cyst is very common case in my practice, but here I can see diffuse Nebulian cyst, which is very unusual. Like here you can't expect Nebulian cyst, and they shouldn't come like this. So it's quite unusual for me to see this amount of Nebulian cyst in a patient. So I think I should look further. So here's the transverse section, and you can see these Nebulian cysts are already getting connected to each other and showing flow within. You can see this venostasis within these channels. So these are actually the venous channels who got dilated. So the diagnosis has changed. So you can see now these cystic areas are interconnected. Actually, these are the tortuous venous channels. So these are the parauterine and the ovarian veins, which are dilated. So you can also see the intrauterine veins. These are also dilated. Okay, so these are arcuate veins actually. So all the venous channels within the uterus and surrounding the uterus and obviously the ovarian one are dilated with internal venostasis. So this is a very risky area for developing thrombosis also. So we call it the pelvic congestion syndrome. So here is the color Doppler, and you can see only this part where you can see the flow within these venous channels. So this is a case of pelvic congestion syndrome. Patient usually comes with a chronic pain of more than 6 months duration. And you can see the dilated tortuous venous channels within the ovarian vein or on the parauterine or even at the arcuate veins level also. So this patient's is the counterpart. I think this is the counterpart of the varicocele in the male patient. So now come to the case number 13. After that, I will just check the Facebook live video. So this is a 53-year-old male patient who came with painful erection. Again, penile. I have missed. I think I have just made a mistake. I was trying to take a scrotal ultrasound picture or case, something. But mistakenly, I have taken the penile case. Anyway, so patient came with a painful erection with a bending. So in this type of case, we try to look for the plaques actually. So here you can see the cross-sectional image of the penile part. Let me freeze a little. You can see this is the corpora cavernosa, and this is the corpus spongiosum. So this is the right side and this is the left side. You can see these are the cavernosal arteries which were collapsed on previous case. So now here you can see the surrounding margin is the tunica albuginea, and here you can see some calcified plaques here, very large calcified plaques within the tunica albuginea, in between the corpora cavernosa and obviously corpora spongiosa also. So these are the plaques, calcified plaques, which are causing painful erection and difficulty in erection also, and causing bending at that part. This is the mid shaft region where you can see these calcific plaques. So they're large in number. So it's not a good condition. Actually, the prognosis, I think, not very good. So here, after some manual massage, you can see penis is slightly erected, but patient was feeling pain, and you can see these plaques quite well right now in between two corpora cavernosa and corpora spongiosum also. So this is the tunica albugineal calcification known as Peyronie's disease. So here's the long section, and you can see these large plaques just making it difficult for erection. So here's the magnified view, and you can see the plaques, which are calcified plaques at the mid shaft. Here's another picture of the mid shaft calcific plaques. In our YouTube channel, I think we have more than one Peyronie's disease case video available, so you can check that also. So this is a case of Peyronie's disease. Okay, just let me check the Facebook Live to just ensure that I'm just talking in a regular manner. Okay. So we have fortunately 103 participants right now. Oh, that's great. We have many participants from different parts of the world. You know, our YouTube channel has more than 58,000 subscribers. And whenever we check the analytical study or analytics, so we see that only 8% people are from my country, actually, and 92% of the viewers are from different countries around the world. And we're very fortunate and very proud for you that every country has at least one subscriber for us. So we are very grateful to you, and thank you for being with us. Let's jump into the case number 14. So these are 11-year-old, okay, male participant right now, and he has a history of laparoscopic appendectomy. Okay, 6 months back. That's not good. It doesn't look good. Uh, there's something abnormality coming. So this is the chronic and there is a history of chronic discharge from the lower abdominal port. So the laparoscopic port abnormality is quite common in our country in some season. So this is the case, I think. So let's look at the abdominal port. So here you can see a sinus tract here. You can see the sinus tract. This is the sinus tract with internal thick content. So this is the granulomatous tissue or inflammatory tissue here. So it extends up to the margin of the muscular layer. So this sinus tract extends from the skin actually. So this is the lower abdominal port, not the umbilical or right iliac fossa. Both ports were normal. So we have put color Doppler and you can see increased surrounding vascularity indicating the inflammatory change. So patient gave recurrent discharge from, gave the history of recurrent discharge from this part. So this sinus tract. So in your, I don't know about your country, but in our country, if we can get this type of situation in any patient with a history of especially with the history of laparoscopic cholecystectomy or appendectomy, we usually get it to be diagnosed as tubercular sinus. So this was also a case of the case of tuberculosis. So this is the tubercular sinus tract. So the sinus tract with inflammatory contents at the lower abdominal port, possibly due to the tubercular infection. Okay, so this is very common sometimes in our country. So you need to sterilize a lot your laparoscopic instruments. So this is a 15th case, and let's start with a 28-year-old female patient with 8 months plus amenorrhea with a history of cesarean section. So previous patient had amenorrhea, so I thought she was a pregnant patient. That wasn't. Oh yeah, that was a pregnant patient, I think. Yeah, it was. I think I have made a mistake in this case. Yeah. I'm sorry. It was a gallbladder case. So this is the previous one. So sorry, this is a male patient with the upper abdominal pain. So the questionnaire is quite different. So mistakenly put. So this is a gallbladder patient, and patient came with a right upper abdominal pain, nothing else. So it was diagnosed already, but sent to me for further confirmation. And you can see this is the gallbladder, and you can see an irregular mass over here. It can be mass, it can be slurs or something else. So we need to further confirm with color Doppler. We can use color Doppler for confirmation. It's very easy. If it is a slurs, you won't see any flow. Sometimes thick slurs may take a long time to move along the posture changing. So it's better to use color Doppler. So we have used color Doppler, and you can see very high vascularity within this mass lesion. So usually gallbladder mass lesions are malignant, and they have good vascularity, and they're very aggressive. So whenever you get vascular flow like this, make sure there should be some hepatic invasion already been occurred. So if you can use the linear transducer, you can sometimes assess the invasion. Probably the fundal part or posterior part got invaded, but as we have gone through the CT scan, so we send the patient for CT. So here's the power Doppler picture, and you can see highly vascular flow within this mass lesion. So here's the high frequency linear transducer view, and you can see this irregular heterogeneous mass within the fundal part of the gallbladder. And we try to look for the hepatic invasion surrounding fat plane or omental fat is thickened. So this fat thickening may indicate the fat surrounding fat bacillus or serosal invasion. So I've put color Doppler, and you can see very good vascularity within this part. So let's take the sample from this vascularity, and you can see a good amount of flow, arterial flow within this mass lesion. So this is a case of gallbladder mass, possibly malignant one. Okay, now this is a case number 16. So this is a 63-year-old male patient who came with a positive history of diabetes, so patient diabetic, and he came for a routine scan. Let's see what we have got on ultrasound. So here you can see the epigastric region. You can see this is the pancreas. I'm just looking at the pancreas. This is the pancreas. I think my machine or bowel preparation is not very bad, but the pancreas looks quite hazy, you know. So you see the brightness over here and at the posterior part looks different. So the anterior part looks relatively brighter than the posterior part. It indicates that the sound beam is getting attenuated by this pancreas, which indicates the fatty change of pancreas. We call it the pancreatic steatosis. Let's change the setting of the machine. So I'm using a little bit contrasty image setting of my machine. Now, here you can see this is the pancreas. It looks quite blurred because of this fatty change. So this is a fatty pancreas. Now, sometimes this fatty pancreas may appear as broad. So let's measure the pancreas. Now the body thickness is more than 2 centimeters. So it's a broad fatty pancreas. So patient also had fatty liver, definitely. So this is a common case in diabetic patients. So this is a case of pancreatic steatosis. Now come to the case number 17. So this is a 28-year-old male patient who came with a perianal recurrent abscess. Okay, so now when I was scanning, there was a very foul smelling discharge coming from his perianal region. So the room was very much toxic. Okay, anyway, let's see what we have got on ultrasound. So here's the perianal region. On the right side, you can see an heterogeneous collection. You see, this is the anal orifice. Like this is the anal orifice at the midline. And just adherent to it, you can see an abscess here. You can see hazy collection and it is communicating to the outside. And it's forming a sinus tract, which is ending at the anal canal. So this is connected to the anal canal or the intestinal wall. So as this sinus tract has two-way connection with the skin and with the intestinal cavity, so we call it the fistula. So here's another view. Let's search for the anal. This one is the fistula. You can see a thick wall here, and we just getting inside the anal anal canal, and we are coming out from the anal region to see its continuation or making it sure that this is a fistula. So here is the anal canals, and it is getting inside the anal canal actually. So this abscess having communication with the intestinal margin or intestinal wall or anal wall should be counted as fistula. So here's the picture. You can see the color Doppler one, and there is no apparent high vascularity because this is a chronic sinus tract. So here you can see this is the anal wall, okay, anal orifice, and it is very much adherent to the anal wall, and you can see this is sloping down and getting connected to the anal cavity here. So it's very difficult. If you do an MRI, you can easily understand the tracks, and many other tracks can also be seen. So this is a hazy debris containing fistula tract, which is causing very foul smelling. You know, you can if you haven't seen this case, you have no idea about how foul smelling can it be. Okay, so this was a case of perianal fistula. Very much neglected case. Like a patient was not very older, and he told that there was a 5-year history. So it's very difficult. Okay, now case number 18. This is a 45-year-old male patient who came with a right epididymal palpable nodule. Oh, okay. So I have chosen the scrotal picture actually. So I thought that I have not taken any scrotal case today. So anyway, this is a right epididymal palpable nodule. So let's see what we have got on ultrasound. Here is the picture of the testes on both sides. So this look quite normal. You can see something over here. So we want to focus it. So here's the picture of the right epididymis where you can see a large cystic area. Yeah, this is an epididymal cyst, but you can see some rain-like flow within this epididymal cystic sac. Now, sometimes due to the high frequency linear probe, we see the acoustic streaming, some movement of the particles happen due to the waves of the sound. But this is quite not look like that. So let's just look with a different probe. So these are the moving substances within. Uh, let's just change the transducer. So here you can see some those were moving quite a lot. So whenever you see this type of raindrop like moving within a cystic lesion or within the hydrocele, these are the sperms or the spermatozoa. So we call it a spermatocele. So this is a case of spermatocele. Now we want to confirm it. And now we want to see more movements within this cystic lesion. That's why I have put this picture here. So we have put color Doppler, and with color Doppler, you can see the motions quite well. Now you can see it's like a raindrop appearance. And you can see this artifacts going on because of this motion. Now, we can see motion with different, another mode, I think we call it M mode ultrasound. Now, if we can use M mode, we can also see some motions here. Have you ever used M mode ultrasound on a case of spermatocele? Let's see what we can get. It's a beautiful image. So here's the picture. You can see I have put M mode and there's the motion of the spermatozoa. You see the spermatozoas are moving. And the M mode will draw a beautiful picture for you showing the motion of the spermatozoa. Isn't it look beautiful? Let's look at another picture. So I have changed it from this part to the here. Now you still can see these motions. It looks very beautiful, very artistic picture. So sperms are very beautiful to create beautiful pictures, but they will get dead. Anyway, so here you can see this motion of the sperms and spermatozoa within this spermatocele. Last picture, I think. So you can see this motion with different colors and different artifacts. So I was taking many pictures so that I can just show them to you. Okay, another one. So we were talking about the motion. So to see this type of motion, we have another mode, like we call it B flow or a B mode flow type mode. So you can see here I have used the B flow option where you can see an angiogram like picture. You can see the flow of the blood quite well, but it's having a poor quality. Anyway, with B flow, you still can see the movements of the spermatozoa within this spermatocele. Now, I'm showing you different modes to encourage you to use them during a regular scan. So this was a case of right epididymal spermatocele. Very beautiful design. Okay, so case number 19. We are at the end, actually. It's just 1 hour left. Anyway, so this 39-year-old female patient came with low abdominal pain. So let's see what we have got on ultrasound. Here you can see a very big adnexal cyst on transvaginal ultrasound, and you can see some echogenic dash dot sign here, and you can see a calcified structure also. So this calcified structure is nothing but the tooth possibly, and these are the acoustic streaming. You can see the movement, slight movement. This is due to the pressure formed by the sound waves. So you can see these echogenic dots. So these are called the dash dot pattern, but dot dash pattern. that indicates that these are hair follicles. So if you cut it, you will get some hair. So this is a case of dermoid cyst, obviously, you all can understand, but this is not the principle for my this view showing. So I have put color Doppler, there was no vascularity, and the lesion was around 9 centimeter long. So it will be an URATS 2 score lesion with a color score of 1. And now what I want to show you, with this machine, I didn't have any 3D facility, like there was no volumetric probe. But sometimes your machine may have 3D facility that is done by manual swapping of the probe. Like, with 3D probe, what do? You just send a lot of sound in a prismatic manner or a volumetric manner and capture a large volume on longitudinal, transverse, and coronal plane. Okay, now similar thing you can do with a curvilinear transducer if your software allows you. Like in my machine, in this machine, this is a Siemens machine. Siemens is also not a sponsor in this video, very bad. So if you put the transducer, you just put or click on the 3D button and you swap the transducer manually. They will collect all the data and they will try to reconstruct a 3D image, which is excellent. All the manufacturers should also focus on that. So I have done it. Now, let's see what was the calcified structure. This is the 3D image that is done with just a curvilinear transducer, not any fancy volumetric probe. So I just manually swapped the transducer and I saw this structure, this tiny structure within this cystic lesion. Maybe the picture is not very good or like the volumetric probe one, but it's workable. Like if I tell you that this should be a calcified structure, what it can be? So definitely this is a molar tooth. So molar tooth will be seen like this on 3D ultrasound inside a dermoid. So isn't it beautiful? So this was a case of dermoid cyst with an URATS score of 2 and obviously color score of 1. Now come to the case number 20. This is a 6-year-old male patient with non-specific recurrent abdominal pain. So, okay, so let's see what we have got on ultrasound. So here's the picture of the liver. It looks quite normal, but when I looked at the portal vein, it doesn't look normal. So here you can see at the level of portal vein, you can see multiple cystic or vascular channels actually, but the regular portal vein like appearance is not seen. So that is important. If you see this type of appearance, but cannot see the portal vein, you should obviously put the Doppler and search for that. So I've put color Doppler and here I can see multi-directional flow. You can see some red, some blue flows here and some tiny vessels, not the regular portal vein that I was looking for. So let's see on real time. So here's the Doppler picture and you can see some flows within these cystic areas or these tortuous vessels. So these are like collateral circulation that we can see in patients of portal hypertension. But this is a young child, so I can't expect cirrhosis and portal hypertension. The liver looks quite normal. So where is the portal vein? So another picture, let's look at here. So I was just trying to search for the portal vein at the proximal part, but there was no portal vein. These are only dilated tortuous channels at the porta hepatis region without any portal vein. Now, are they arteries or vein? So we have put pulse wave Doppler and you can see these are the venous channels. So they are acting as collaterals to supply the liver in absence of portal vein. So this is a case of congenital absence of portal vein. It has a regular name, so we'll use that. But let's look at the infra vena cava in this patient. As there is no portal vein, definitely there should be something abnormality going on in splenic vein and supramesenteric vein who form the portal vein at the portal confluence. So there should be something abnormality going on there. Now let's look at the abdomen. So I'm at the umbilical region, and you can see multiple venous channels here. So these are some venous channels. You know, some mesenteric veins are not very vascular. Like if you put Doppler, you'll see some flows, but not a very high flow. But when we put color Doppler, we see the aliasing within these veins. So these are something unusual in our regular practice. So in case of absence of portal vein, you should search for the drainage of these superior and inferior mesenteric veins, which may happen into the inferior vena cava, or they may form another vein and collaterals, whatever. So this type of situation is commonly known as Abernethy malformation. So you can go for an hepatic angiogram or then further evaluate the patient. So this is the Abernethy malformation where you won't see the portal vein. Now the case number 21. So this is a 22-year-old female patient who had a history of previous cesarean section, and she came with the cesarean section site pain and something hard palpable thing, and the pain increases during the menstruation, which took our attention. Actually, there was no discharge from the scar site. So let's see what we have got on ultrasound. Here is the scar site. It looks quite normal, so I was confident that there is nothing abnormality going on transverse section. So we put color Doppler, obviously, and there was some neovascularization going on here. So you can see some vascularity there, not should mention the neovascularization anyway. So there are some vascular channels. So definitely there should be something abnormality going on surrounding area. So here is the surrounding part. We have put the color, we have put the transducer longitudinally and swiping it from medial to lateral. We have put transversely, so swiping from the superior to inferior. And now we have seen this lesion here. So you can see an irregular, heterogeneously hypoechoic area at the subcutaneous layer, just below the skin. So this took our attention. You can see surrounding fat is slightly thickened. So there should be some inflammation going on also. So we have put power Doppler and you can see some flow, color Doppler, and you can see some flow at these parts, but not much severe flow. So this is a case of scar endometriosis. So this is the scar endometrioma. You can see the irregular appearance with a heterogeneously hypoechoic area. If you can scan the patient just at the 4th or 5th day of menstruation, you can see some fresh fluid or anechoic blood or echogenic blood within this endometrioma. So heterogeneous nature is more aggressive at that time. So we have put color Doppler and there was no prominent vascularity. So we have took sample from this some vessel and just getting some high resistant flow here. So this is a case of cesarean section scar endometriosis. Make sure the lesion itself doesn't have any vascularity. You only can see the surrounding vascularity due to the inflammatory change of the surrounding subcutaneous fat. Okay, now case number 22. After that, I will just check the life again and then we'll come back. So this is a 65-year-old male patient who came with the claudication. He can't actually walk. After 1 or 2 steps, he feels very pain. So let's see what we have got on ultrasound. So we started with the right iliac vessels and external iliac vessel and the common femoral and obviously all the vessels, large vessels, and all the large vessels of the right lower limb show the monophasic wave pattern, which is a dampened flow here. You can see the slow rise of systole and the long diastole, which indicate there is something abnormality going on prior to this vessel. So proximal to this vessel, there should be some obstruction or something like that. So we need to see the opposite limb also to understand the level of obstruction or stenosis. So here is the posterior tibial artery in this patient. The lumens are showing some atherosclerotic change, but the flow velocity is very low here. So these are the dampened flow. You see the anteriotibial artery also has a very narrow lumen at this part. But when we were checking the flow, you can see like a vein-like flow within this anteriotibial artery, which indicates that there is a very sluggish flow in these vessels. So we have checked the left side, and left side also shows similar feature. So if one side shows the feature of tardus purpose or dampened flow, then we would focus on the iliac vessels. But as you can see, both sides are showing monophasic dampened flow. So there should be something abnormality going on in the aorta. So we need to search for the aortic obstruction or severe stenosis. So here's the posterior tibial artery on the left side and anterior tibial artery. Both are showing the monophasic wave pattern of dampened nature. So let's look at the aorta. So on transverse section, you can see the aorta is going from anechoic to heterogeneously hypoechoic, indicating something inside the lumen here. So this doesn't look normal. So this is the transverse section. So let's look at the long section. You can see the aortic lumen is pushing here. So this is an echogenic plaque over there, which is causing the luminal stenosis or occlusion, and the aortic flow is trying to push them downward. So we have put color Doppler, and on color Doppler, you can see there is a flow up to this level, and then from this part, there is no flow. Even on transverse section, you can see this is the inferior vena cava, this is the spine, anterior to spine. On the left side, this is the aorta. And on aorta, inside the aorta, you can't see any flow, but you can see multiple flows surrounding this aorta. These are the collaterals. So you are obstructing the aorta. Definitely you should make some collaterals to ensure your limbs to survive. So we have made some collaterals here. You can see this is the aortic occlusion and there is no flow here. And these are the large collaterals coming out from this part of the aorta, proximal part, and giving supply to the lower limb vessels. So here you can see this is the aorta giving a good flow, but at this part there is no flow distal to here. I'm compressing a little and you can see some collaterals coming out from the distal intact lumen of the aorta. So there is the complete occlusion of aorta. So here's another view and you can see these collaterals coming out from the aorta. So these are large vessels. If you do a CT angiogram, you will see a lot of vessels surrounding this part. So here's another view and you can see these collaterals, which is important to make your limbs survive. So this is a case of aortic iliac disease, or you may call it the aortic occlusion. Now, case number 23. This is a 38-year-old male patient who came with an elbow swelling, so at last a musculoskeletal case. So there was pain and difficulty in movement, so the elbow swelling is very common. We have shown you a musculoskeletal case. I think it was the supratrochlear lymphadenitis. Okay, so here you can see the elbow joint shows at the over the olecranon process region. You can see it's fluid collection. There is a localized fluid collection with some fat plane irregularity. So this type of localized fluid collection adjacent to a joint with some fat plane irregularity are usually bursitis. So they may even cause the abscess formation in some cases, but it's quite uncommon. So commonly they came with a severe pain and difficulty in movement. So this is a localized collection with fat plane irregularity over the olecranon process. And this is called the olecranon bursitis. Let's look at another picture and you can see some hazy content. We thought that there might be some pus collection on aspiration, but the collection on aspiration shows regular serous fluid yellowish color. So we were shocked actually. So this was a case of olecranon bursitis. So if you see any cystic dilatation at this part, so you should obviously focus on olecranon bursitis. So you can see this fat plane irregularity with a localized collection at the level of olecranon bursa. So we have put color Doppler, and on color Doppler, you may see some vascularity due to the inflammatory condition. The bursal vascularity or wall vascularity may get increased. So this is a case of olecranon bursitis. Okay, case number 24. I had to look at the Facebook Live, but I missed it. Anyway, so 65-year-old male patient came. Okay, so I have made another mistake. So the data is not accurate. Okay, just let me clear it. So this was a child. This was a neonate. This was a neonate. Came with a history of birth asphyxia. Okay, now he had got. So this is not neonate. I think this is a child. I'm making another mistake. Okay, forget it. So the patient had a history of birth asphyxia. Then a history of hydrocephalus, and he had to gone through BP shunt, so to drain the CSF. So let's see what we have got on ultrasound right now. So it's around 1 month old baby, I think 1 month or something like that. So so here you can see there are multiple cystic areas within the brain parenchyma. You see, so multiple cystic areas. And where's the ventricle actually? Let me freeze the image a little, something I have seen here, I think. So this is the lateral ventricle on the right side. You see something coming here. So this is the VP shunt. This is the VP shunt, which is entering into the left ventricle. So here's the left ventricle. This is the right ventricle, and it is compressed. Right ventricle is compressed due to this cystic lesion. And here is another large cystic lesion here, which is also compressing the left ventricle, lateral ventricle. And if you look here, let me freeze a little. I think the midline is displaced a little. So there is a mass effect going on. So the condition doesn't look quite normal. There are multiple cerebral parenchymal cysts causing midline shifts and compression over the ventricle. The right lateral ventricle has its frontal horn dilatation. So this should be a case of proencephalic cysts. So let's look at the picture. You can see the right frontal horn is dilated. The left frontal horn is not dilated because there is a BP shunt put on into that part. But there's many cystic areas within the brain parenchyma, which are called the proencephalic cysts. So you can see the right lateral ventricle is compressed over here. And if you look at the midline, it is slightly shifted towards the right side. So let's use the high frequency linear transducer. You can see this is the VP shunt entering into the left lateral ventricle, and this is the foramen of Monro level, I think. So the right ventricle is dilated, but the left one is not dilated. So this is the type VP shunt, how it looks. So here's the BP shunt. You can see it's entering into the left lateral ventricle. So it's just making it to drain quite well, but the left lateral ventricle and the right lateral ventricle is still slightly dilated at the frontal horn due to the compression by the cystic lesions at the other parts. So this is a bilateral proencephalic cyst with mass effect and midline shift towards right. Okay, so the dilated frontal horn of the right lateral ventricle is also seen, and the BP shunt was in the frontal horn of the left lateral ventricle. Not a good condition, I think. So to this last case, this is a 35-year-old female patient with a severe lower abdominal pain and regular menstrual history. So let's see what we have got on ultrasound. So here you can see the curvilinear transducer view. So the patient was sent for the lower abdominal ultrasound scan, but when we tried to scan the lower abdomen, the patient didn't have a good bladder preparation, but the patient was toxic, and you can see patient had severe lower abdominal pain actually, and we can see it's something abnormality happening at the lower abdomen. So we need to examine the patient with a full bladder, or we should go for the transvaginal ultrasound. So it's a difficult situation right now. If you're from Bangladesh, you should check the time. So it was on the 4th August at the 12:57 p.m., which is a very crucial time for our country at the time. And especially in front of my chamber, it was a very devastating situation going on at that time. So we did a TVS in this patient because we told the patient to go for a good bladder filled situation, but the patient suddenly got vomited a lot, and she doesn't look quite good. So we advised him or recommended her for the transvaginal ultrasound, and she agreed with us. So we started the TVS, and you can see on TVS, we can see a cystic area with thick wall at the right adnexa. We have already seen something bad. And now when we are looking at this structure, we definitely want to look for the ectopic pregnancy. So we have put, make sure the patient has a good menstrual history. So that may make you confused. So we have put color Doppler, and you can see a little vascularity surrounding it. If it is an intact gestational sac, you'd get good vascularity, but if it gets ruptured, then it will be difficult, or sometimes you may not get a very good ring of fire appearance. So it will also make you confused. So we have took sample from different parts of this sac. So perisac vascularity showed a resistive index of 0.43 or 0.54. We are not satisfied because this is the range when you see a ruptured ectopic pregnancy. So we have scanned a little to see the surrounding region, and you can see these are the fallopian tubes. And you see this fluid here. This is the acute blood. Okay, so this is not the pouch of Douglas, something normal fluid collection. This is the typical appearance of acute fresh blood. So if you want to detect earlier, you have to look at this color. This is the color of the fresh blood. So the patient is on an active bleeding state. So unfortunately, after just this examination, patient went to shock. So we were very fortunate that our gynecologist helped us, and all the team members of my center helped. So we could manage the patient, and I'm not working in a hospital, so that made a little difficult. So patient was sent to nearby hospital, and the gynecologist and all her team members made a good rapid surgical correction, and there was a huge blood surrounding this gestational sac and the lower abdomen. So patient fortunately survived that situation, because at the time, all the shops, stores, and everything were closed due to some issues, which my country people knows. Okay, so this was a case of ruptured adnexal ectopic pregnancy. Okay. So, and that's all for our today's session. So I wish you all again the International Day of Radiology 2024. So fortunately, with other countries, we also trying to celebrate it with a different style, you know. So anyway, if you are from my country, we have some paid webinars in this month, and you can see the schedule here. And also you can check our imagingstudy.com for the registration process. So if you're from not from my country, don't get angry, because we don't have any payment system available or for the foreigners. So that's why we can't actually include you in these sessions. And obviously, these are on our local language, so you won't be able to understand what we say. So we have a free session also in the 22 November, I think. That will be also Friday. So we're trying to take free sessions on every alternative Friday. So if you are here, just know that on every alternate Friday, we'll try to arrange a free session at this time. So if you are interested, you can attend that. We'll just make some ultrasound cases or something like that. So anyway, so we have a YouTube channel, we have mentioned already, that is known as Imaging Study, has got 58.5K subscribers. Thank you all. I'm very grateful because my targeted participants are very limited. I make ultrasound contents and they're very limited persons who are interested in learning the ultrasound. So 58.5 is very big amount for me because I was targeting to get 20,000 around in my lifetime, actually. Okay, so thank you. And we have a website named imagingstudy.com where you can get our registration processes and our next schedule. And also you can get our some case demonstration and case data here. So you can just check them if you need. So thank you for joining me from Facebook. And also this video will be uploaded in our YouTube channel after the record is available. So if you have any question, just you can ask me on our live video, not in the groups because it will be difficult. Okay, we have 100 around participants, I can see. Okay, there is a question. We'll repeat our carotid Doppler class, but it will be rare because we have already repeated it, I think, 3 or 4 times. So it should be difficult for, I will just try to take a break on December or January, I think. So after that, I may repeat it. I've got 2 cases of Abernethy malformation, actually. This case was given by a doctor. The patient is also a relative of a doctor. Yeah, the record will be kept here. Don't worry. I'm very much unavailable on my phone because I think on Sunday, one patient called me 24 times in the morning, and I had to just switch off my phone, and I missed very valuable phone calls on that day. 24 times calling is very rude, actually. Okay. Okay, the acute blood will look like this. Okay, in acute blood, you'll see it will be echogenic. Like you say, hypoechoic, no problem. This is actually an echogenic blood. So echogenic blood is found in the acute cases. And these are the fallopian tubes. Let me show you. So these are the clumped fallopian tubes, and this is the blood surrounding it. me just check the question from different view. If you have any question, just you can put on the live. I don't have any bladder flap hematoma case. I think I have. I'm working in a very safe area where you won't see any risky or emergency cases. Like this case came to me in a very bad situation. Like the tanks, the armies were just in front of my chamber, and there was fighting going on, and it was very crucial. I think on in last 1 year, this is the emergency case that I have seen. So it's very unusual. I think my abscess was not looking anechoic. It was looking hypoechoic, but I was decreasing the brightness. So whenever I go for the lower abdomen, I try to reduce the brightness or gain to understand the surrounding lesion, surrounding abnormality. So it was not anechoic. It was a little dark. And whenever the abscess gets healed, it gets relatively darker or relatively echogenic, depending on the internal contents. So if you see the density content or increased density content within this abscess, then you will see it to be a little bit echogenic. If the density is relatively low, then it will get hypoechoic. But whenever I see the try to see the lower abdomen, I usually decrease the gain a lot so that it doesn't make any disturbance to see the adjacent areas. And you see, I frequently use Doppler. So to use the Doppler, I usually want to reduce the gain to get a good result. The main difficult scenario is that I am not um, getting the old messages. So let me check the old messages. In case of confusing cases, you easily can differentiate abscess or cystic lesions. Like abscess should have an irregular wall unless it is a healed abscess, because healed abscess will turn into a cystic lesion frequently. So the abscess will show you the surrounding fat irregularity and fat thickening. We with CT we call it the fat stranding, and the cyst, if it is not infected, it won't disturb the surrounding tissue. Moreover, if you use color Doppler, the surrounding vascularity will be high in case of abscess. Obviously, the abscess will create a very big inflammatory zone surrounding it. But for the cyst, you won't get any vascular changes. So the color Doppler is the very easy technique to differentiate between the inflammatory and non-inflammatory conditions. PID is an elaborated term. Whenever you try to say PID, you should show the patient is having salpingitis, euphoritis, endometritis, bulkuterus, thickened endometrium, pouch of Douglas fluid, endometrial cavity fluid. So all these things should come. So it's better to stuck with a single diagnosis like endometritis or salpingitis or something like that. So combination diagnosis should be done by the clinician as far I prefer. And adenomyosis with PID is a very complex communication. So you need to create some inflammatory environment or something like that. So it's very difficult. So rather endometritis may have the relation with the PID, because at the level of fallopian tube or surrounding area, it will create abnormal problem. So that's why there might be a chance of fallopian tube dilatations, and the inflammatory conditions may proceed and go for the pelvic inflammatory disease. So rather than adenomyosis, endometritis and in endometriosis both may cause the PID-like features or create PID. Okay, so I don't know why I can't see the previous comments. Actually, okay, any hematoma will get changed over time. You know, the content of the blood will get changed. So the rule is that the fresh blood will, like in a very active bleeding state, it will come as echogenic blood. Then it will turn into hypoechoic, then it isoechoic, hypoechoic, then anechoic, and then absorbed. This is the rule of the hematoma, usual rule. And if you talk about the fibrosis, that is quite opposite. Like when you are healing an area, it will be edematous, so it will get darker. So it will be hypoechoic, then you will get isoechoic, then you will get the fibrosis over there, and that it will be hyperechoic. So at the end, scar will end up as a hyperechoic, except for the keloid. If there is a hypertrophic scar, it will be hypoechoic. Okay, so it's a little bit difficult thing in our regular clinical practice to differentiate between the adnexal cyst and um, the ectopic pregnancy, and it makes a little bit confusion. So in case of ectopic pregnancy, we'll get a thick-walled sac. So sometimes the corpus luteal cyst also may come with a thick-walled sac. So the history may guide us a little further, and the patient will come with the specific adnexal pain. And if it gets ruptured, then it's very easy, because you will get a good collection. And also the patient's complaint goes in favor of ectopic. But in the stable stage, when the sac is present, you can't see any content inside, and the wall is already intact. It makes us confused. So at the time, we use the color Doppler. In case of color Doppler, if you see the perisac vascularity resistive index less than 0.5, it goes in favor of ectopic, but it is not very specific. So if it goes less than 0.4, then you should be very careful, because this is an ectopic. So ectopic, intact ectopic pregnancy usually has a perigestational sac vascularity of less than 0.4. But if it gets ruptured, then the resistance get higher, because there is no more need of a good amount of flow inside. So at the time, we get confused. So it's a combination of history, combination of ultrasound picture, grayscale ultrasound pictures, and obviously with the color Doppler pictures. But if you want to confirm, you definitely should go for the TVS. The transabdominal ultrasound is not the best modality to ensure it to be an ectopic, but we have to use it a lot. Whenever you are trying to say PID, PID is a combination of many different scenarios like salpingitis, euphoritis, endometritis, bulky uterus, thickened endometrium, pouch of Douglas fluid, endometrial cavity fluid, whatever. So that's why it's a complex collection of diseases. So it's better to report whatever you get, not try to focus more on the making a diagnosis of PID, which is easily diagnosed with the clinical clinicians. So better we should comment on the findings we got. Like only a 10 ml or 10 fluid in the pouch of Douglas doesn't suggest this is a PID. So it's a very bad practice to find only a pouch of Douglas fluid and say PID. Because we don't know from where that fluid came. It may come from the liver disease or from the renal disease. So why it should always be PID? It's easy to differentiate between the euphoritis and torsion. Euphoritis and torsion both come with a large hypoechoic ovary, but on grayscale you will see the echogenic margin of the follicles, which is called the ring sign, which is definitive for the ovarian torsion. And in case of euphoritis, you won't see this like feature. There will be some collection and enlargement, fat thickening, all may present in both. But in case of torsion, you will see no vascularity, or you may also see high vascularity definitely at the peripheral part, but central part usually has no flow. As ovary gets dual blood supply from uterus, uterine artery and ovarian artery, it is not necessary to close all two arteries to create a torsion situation. But if you want to drain the blood, you have to use a single channel of vein. So that's why in case of ovarian torsion, you won't see any venous flow inside the ovary, which is more preferable for the torsion. So in grayscale, you'll see the ring sign, and on color Doppler, you will see the absence of venous flow, which is more preferable for early or easy diagnosis. No euphoritis, the vascularity gets very high. In case of torsion, you'll get a good vascularity at the surrounding part, but the vascular resistance is quite high. Euphoritis has having inflammation, so the flow will show you a good diastolic component. There is a question about the stone and calcification. Whenever you see a calcified structure within a lumen, you will call it a stone. Like within the gallbladder, within the renal sinus, within the ureter or urinary bladder or urethra. These are the stones. But if you see the calcified structure within a solid tissue or within a parenchyma, you will call it a calcification. Like you are looking at the renal parenchyma, you are seeing at calcified structure. This is the stone. And this is the calcification. Like you are seeing the calcified structure within the wall of the gallbladder. This is calcification, but within the lumen, it will be stone. So lumen means stone, parenchyma means calcification. Both are calcified structures, actually. Oh, it's a difficult thing to diagnose pyelonephritis with ultrasound. It's quite easy in CT, where we can easily see the air. So if you see the kidneys are echogenic, you see the hazy internal content or the fluid, okay, that's okay, but it may also occur in the acute glomerulonephritis. So it's better to wait for the air. So if you see any air or air shadow from the kidney, you definitely be confident to say it as a pyelonephritis. Or rather, you should stay with the acute renal parenchymal disease or acute nephropathy, depending on which center you are. So it actually depends on the center, but it's better not to be more specific. Give your clinician to diagnose a little. So we want to help the clinician with our diagnostic tools. not to make a big diagnosis and put it on his head. Okay. Anyway, we will have to finish. So if you see a brachydegenic structure without any post-acoustic shadow, it might be so many things, like it might be worm, it might be soft calculus, it might be slash ball, or soft calculus are quite same. So there are many things that can happen. Even a polyp without any movement, it can be polyp if it is attached to the gallbladder wall. So mass may also not show any shadow. So it's not necessary for a stone to cast shadow. To cast shadow, you have to resist the sound from the surface. So usually 2 millimeter or more than 2 millimeter calculi can actually handle that sound, resist that sound from passing through them. So usually calculi less than 1 millimeter may not, or less than 2 millimeter may not cast any post-acoustic shadow. Obviously, it is also dependent to the transducer and ultrasound beam you are putting over the calculus. So usually we see the soft calculus, which is the preformed calculus, doesn't show any shadow within the gallbladder. Oh, there is a lot of question here, but we don't have a lot of time for that. There's a huge, large question. Yeah, cholesterol balls also can be seen in the gallbladder lumen and may not cast. Okay, we shouldn't go outside our this this part. Listen, there is no specific rule for the gain adjustment to see the debris. It depends on your machine, it depends on your preset, it depends on your transducer. So you have to know with which transducer setting in your machine you can see the debris. Like in my machine, if I have adjusted a lot, I have changed a lot of presets. So when I use my regular abdominal preset, I can't see any debris within the urinary bladder. In very severe case, I even can't see any debris there, because I have changed the contrast to assess more beautifully the liver lesions. Now, when I'm going to look for the urinary bladder and trying to search for the debris or urinary bladder luminal lesions, I just swipe my preset to the bladder one, which I have already made, and then I can see that lesion. So I've changed the contrast, changed the gain, so everything's. So that's why just changing the gain may not give you the good result. Listen, coarse liver and HCC is quite different. So if the parenchyma is altered, you can see the heterogeneous nature, or it may look quite different. You always should use the linear transducer. With linear transducer, you easily can see the course pattern. It's just for all. If you can see a patient, you are confident that this is a case of coarse hepatic parenchyma, or this is a case of cirrhotic liver, you should always use the linear transducer. If you ever seen the liver with a linear transducer in a patient with coarse parenchyma, you won't ever make confusion with the coarse nature. So just try to use the linear probe and you can solve that problem. Okay, anyway, we have to close. We are out of time. So thank you. The question won't ever end. So we'll try to solve many questions, and we have also got some your choice topics. So we'll try to solve them also in the next session, which will be held on the alternative Friday. So thank you for joining me. Hope to see you on the next session. Wish you all the best up to the next meeting. See you on the next one. Have a nice day.